Greetings, ladies and gentlemen. This is Prosthodontics on Friday, which addresses various prosthodontic steps in implant treatment and side effects. I am MC, Dr. Jo In-ho. As a fifth of the problem-solving series, we have invited Professor Jo Kyu-sung, Professor Emeritus of Yonsei University Dental School, to provide us a lecture on peri-implantitis prevention and treatment related to implant prosthesis. Hello? Today is the first time for us to choose peri-implantitis as theme. Could you please briefly explain about your lecture? It can be divided largely into two. The first part is about peri-implantitis, in other words, peri-implant disease, the overall explanation on that. And the second part is about treatment of peri-implantitis. I tried to put it briefly. I really look forward to your lecture. To those watching the clip from Dental's site on the right, using the chat screen, you can communicate real time. Please raise your questions freely and they will be addressed during the Q&A period. I hope you show a lot of interest, and now we will begin the fifth lecture of problem-solving series with Professor Jo Kyu-sung. Today I'm going to talk about peri-implantitis, prevention and treatment related to implant prosthesis. Last year, August 2020, I've closed the chapter as working as a professor at periodontal department at Yonsei University after working there for 35 years. Fortunately, without causing earth-shattering problems, I bowed out as Professor Emeritus, and I have followed Professor Cho's footsteps. Congratulations! I first came to know about implant in the 1990s at UCLA. It's approximately 30 years ago. Professor Cho In-ho, Professor Hong Sun-ho. I wrote the names down so that I won't forget anyone. Professor Kim Ho-hwan, Professor Lee Gun-ho. The times fly by. I prepared for approximately 1 year, and in 1992, for the first time, I placed my first implant. At the time, President Clinton and President Kim Young-sam was inaugurated. Seo-tae-ji and the boys were debuted, and one of them is now owner of YG Entertainment. Time flies by. The first part of my lecture is about introduction of peri-implant disease. I'm going to briefly talk about 4 items. And second part is going to be about non-surgical treatment and surgical treatment of peri-implant disease, followed by conclusion. The definition of peri-implant disease. This is something that you all know, but considering that this is the title, let's look at it briefly. 2.5 millimeter peri-implant bone loss, over 6 millimeter of probing depth, bleeding on probing and separation are proposed as diagnostic criteria of peri-implantitis. The definition can vary depending on textbooks. Prevalence of peri-implant disease. Briefly said, in 2012 at EAO consensus, it was reported that 1 out of 5 patients, 1 out of 10 implants had peri-implantitis. As a dentist, You need to inform the patients of the risk of peri-implantitis. And preventive measures need to be explained and taken in order to prevent suffering on the part of the patient. Before retirement, for about 10 years, about half of my implant treatment cases involved peri-implantitis. It's probably because I've been placing implants for over 30 years. What is the difference between peri-implantitis and periodontitis? If you look at this image, because of anatomical and histological difference, on the right, supracrystal fibers are healthy, and even if there's inflammation, they're self-limiting and protective connective capsules are formed. However, in the case of implant, such connective force is weak, as shown here. As shown in the yellow, the inflammation can progress very quickly and it can progress towards the bone marrow. And it occurs very quickly. That is why we provide anti-inflammatory drugs and provide systemic antibiotic to prevent bone marrow infection. That is my opinion. Let's summarize once again. Periodontitis. Because supracrystal fiber is intact, it progresses slowly, and peri-implantitis, because there is no healthy connective tissue fiber attachment, it can progress directly into the bone marrow. So once diagnosis is made, you should not delay it and you should treat it as quickly as possible. Risk factors are very well known: biofilm, plaque, poor oral hygiene. This is what we already know. For patients with periodontitis history, they're more prone for peri-implantitis. Therefore, periodontitis management needs to be done thoroughly and implant treatment needs to be done. Systemic factors are diabetes, and environmental factors can be things like smoking. Professor Jo Young-ho is going to talk about iatrogenic factors. I think he's going to talk about prosthodontic treatment in connection with iatrogenic factors. I'm periodontist, so I'm not going to go deep. The cement. I've seen so many patients, and a lot of people use cementation type these days. If you take X-ray, it is fortunate if you can see cement. I'm not really sure, is it resin cement? But that does not show on X-ray after prosthesis delivery. If there is a sudden bone loss and inflammation, it's not 100%, but if there's inflammation within a short period of time, there are a lot of cases where there is cement. When you take X-ray, you cannot see it. The older version, you may be able to see it. I think you need to remove cement very thoroughly. You need to put in a lot of effort. People use more cement type these days. You need to pay more attention to the margin, especially on the anterior side. After prosthesis delivery, you need to look at X-ray and check whether there is bone loss or not. This is the same for this case. On the prosthesis, you can see cement. The patient received treatment from local clinic and the patient came to me. I wouldn't be able to place implants like that even if I wanted to. It's quite unbelievable. As shown, I took CT. No one will want to place implants like this. I'm sure there is a reason for it. I've seen so many implant malposition cases, and I'm going to show you some of the most noteworthy. I'm sure there's a reason for placing implants like this. The implant to implant distance is too close. It needs to be at least 3 millimeters apart, but if it is too close, it can be cause for peri-implantitis. When you place the implant and during prosthodontic phase, there can be many iatrogenic factors created by a dentist. Daniel Buser has mentioned that dentist is the biggest risk factor for implants, and these need to be prevented. Can I ask you a question? You have talked about malpositioned implants causing peri-implantitis and bone loss, and there can be many cases. Let's think about ways to solve this. Digital guide, it has been the latest trend gaining popularity, and we have one guide at Osstem. Using one guide system, do you think it will help with preventing malpositioned implants, such as implants being placed too close to each other? Everyone wants to place implants in the correct way, and those with a lot of experience may be able to place implants accurately, buccolingually and mesiodistally. However, there are cases where it doesn't really work out. It's not easy to find the right path. When you ask the patient to close mouth, and the patient won't be able to if it's placed wrong. These days, digital dentistry is available. People use a lot of stents and guided surgeries, and these can be created easily. Using this, you'll be able to find the right path or be able to place the implant in the correct depths. And there's CT. The world is changing and you need to adapt it very quickly. Osstem One Guide, you said. Is that correct? Yes. I think your generation could utilize these great innovations. Thank you. Please carry on. This is a sensitive issue, but this is my personal opinion. Long-term results of various implant systems. Depending on surface and design, in terms of peri-implantitis, I like to point out a couple of points. Implant surface include machined, anodizing, and SLA. Implant design can largely be divided into bone level, tissue level, and whether it has micro thread. You can talk about external and internal thread, but it's bone level. You no longer place machined surfaces. However, a couple of decades ago, in 1990s, I placed them. When you place them, sometimes you would have self-doubt whether it would osseointegrate. This is after 12 years. There are many great cases. The machined surface is really strong against peri-implantitis and it progresses slowly. It may be my personal opinion, but I think a lot of people who have placed implants for a significant period of time agree. You can see that it's clean here. There are many cases, but I've been asked to remove some slides. This has the exact same design. It is anodizing surface. I've used it for about 10 years. One is anodizing and one is machined, and they have the same design. Anodizing surface is prone to peri-implantitis, and after 14 years, if you look at the X-ray, it's like this. I no longer use anodizing surface. Let's move on to tissue level implant. Straumann, Osstem, a lot of companies offer tissue level implants. It's been 13 years since I placed it, and in terms of peri-implantitis, tissue-level implants show good prognosis. I worked with a graduate student on this paper. It hasn't been that long. We've looked at 1,692 implants over the duration of 10 years. Survival rate and loss pattern, as well as marginal bone level, was observed. It was published twice in Clinical Implant Dentistry and Related Research. It was 2 years ago. Survival rate is 98.23%, and it is very similar to the Danielle Buser result, which was 98%. The bone loss was minimal. In terms of peri-implantitis, I think it's okay. There are a lot of companies that offer this option, and there are designs with microthread and without microthread. Up until the microthread, you can see that there's bone loss. It doesn't occur immediately, but with time, there's severe bone loss. Personally, I'm sure some people disagree with me. This is just a summary of my personal opinion. In terms of implant design, people no longer use cylinder type. I think it is clinically acceptable to use wide, short, narrow implants, and there are many literature on this. Microthread design, long-term, is prone to peri-implantitis, and tissue-level implants show low rate of peri-implantitis occurrence compared to bone-level implant. And machined implants, it's difficult to have successful surgery, but it is strong against peri-implantitis. Anodizing surface is prone to peri-implantitis in the long term. This has been the summary. Next part is about treating peri-implant disease. Peri-implant disease is quite rampant these days, and I think a lot of dentists have difficulty in treating peri-implantitis with long-term patients. A lot of people use non-surgical therapy. People use mechanical treatment as well as antimicrobial treatment. In other words, non-surgical treatment. There are mechanical treatment as shown. I'm sure you're all aware of these. There are multiple tools. There's ultrasonic scaler for implant. Also, there's a product from Osstem. Some have plastic caps. Most of them have plastic caps. Some are in metal. I think you need to be equipped with all of these. In order to prevent the scratches on implant surface, there's ultrasonic scaler made of copper. Air powder polisher is shown on screen. Our brush was introduced by a certain company. This is not for non-surgical therapy, but you need to be aware, and there are lasers as well. You need to use them appropriately. What I want to mention is you need to have antimicrobial therapy. Chlorhexidine is the most well-known antiseptic therapy. You need to put it in the pocket, or in addition, you can use local antibiotics. In other words, local delivery system which releases slowly. There are some local products and others are from Japan. I think Osstem needs to develop it as well, make a good syringe and use minocycline type of drug, you can put it in the pocket so that it is slowly released over the course of a couple of days. I talked that peri-implantitis can lead to bone marrow infection, and if systemic disease is very severe, you can prescribe systemic antibiotics like metronidazole. The most famous metronidazole is Flagyl, and if it is 350 milligrams, the patient would use it 3 times a day for 10 days. There are many different literature, but this one speaks to me the most. Using antimicrobial therapy and mechanical therapy repeatedly. You don't just do it once, but you do it in a repeated way. And if you do this, you can get good prognosis clinically. Using mechanical treatment and antibiotic is very good. If you use minocycline subgingivally, you can get very good results. This is not just one-time treatment, you do it multiple times. For example, it looks like abscess. Using syringe, putting in minocycline, if you do it repeatedly, even without additional treatment, you can get this kind of result. In the bottom, it's not as severe as the one on top, but there's bleeding and there's inflammation in proximal. The therapy I'm talking about is very simple yet effective. At periodontal department, per month, we use approximately 600 of these antibiotics. This is a case. ITI implants were placed. 7 years later, peri-implantitis occurred. Mechanical treatment in addition to antimicrobial therapy was done. Flap surgery was not done. After 1 year, so 8 years after implant placement, it is not 100%, but compared to initial visit, it's not re-osseointegrated, but bone fill has occurred. It looks much better. Non-surgical therapy takes up 80 to 90%. You need to prepare the drugs and provide such therapy. Rather than just doing mechanical treatment alone, do it adjunctively. Mechanical treatment alone can be unpredictable, but adjunctive antimicrobial therapy can lead to better BOP and probing depths. Can I ask you a question? You have mentioned earlier that adjunctive antimicrobial treatment, if you do it regularly, it's not regularly. This should be done repeatedly. You do it every couple of days. You said that you can get better results. In my opinion, if you do it repeatedly, we brush our teeth 3 times a day. Why not add antibiotic within the toothpaste? Maybe that will lead to better results. It just occurred to me right now. What's your opinion on this? Adding antibiotic to toothpaste, this could cause problems. You need to develop different types of antiseptics. I am aware. Osstem also has toothpaste. And maybe you can use that together, but antibiotic, you need to put it in the pocket. Antiseptic is the same. You need to put it directly on the pocket. It's a local delivery system, so it needs to be slowly released in the course of a couple of days or maybe a week. I think it is better to develop minocycline type of drug to be used with syringe. When you brush your teeth, it only goes up and it does not go inside. I understand. Thank you. Please carry on. Surgical treatment I'm going to go over quickly. It can largely be divided into resective surgery and regenerative surgery, depending on the defected shape. When you remove pocket, that's called resective surgery. If you do a lot of bone graft and GBR, that's called regenerative surgery. Amongst the resective surgery in the anterior aesthetic zone, you open flap and then close and do a set access surgery. In order to reduce the flap, at times apically portioned flap can be opened. The most important thing is to do decontamination on implant surface. On natural tooth, you call this root planing. There are many journals and literature available: air, powder, chemical agent, remove using gauze. There are different ways, and there's no defined way that is better above other options. Some books say just use gauze and due diligence using gauze. You need to decontaminate the implant surface as much as possible. Let me show you a flap access surgery. If you look here, in number 11, there's a fistula in the middle of number 11. On X-ray, it's like this. When I open the flap, I removed the inflammation. This is the aesthetic zone. Full decontamination was done. Now it's after healing. It's nicely healed. This is the type of access surgery. When I opened the flap, bone loss was very severe. It wasn't infrabony pocket, but horizontal bone loss occurred, and the flap was adjusted to reduce the size of the pocket. In number 17, mesial of the implant, you can see that I have circled it on the X-ray. Bone loss was very severe. Flap was opened. Apically portioned flap was opened. On the right side, the most distal one, flap was opened and implant was exposed to reduce the pocket depths. Apically portioned flap can be opened in this way. If you want regeneration on the defect shape is very important. The bone graft and membrane can be used when we do this. Let's look at the classification of peri-implant defect. The circle one is implant and the yellow is the bone loss. You need at least infrabony pocket. Class 2 is horizontal bone resorption. In the case of class 2, resective surgery is recommended. In the case of class 1, regenerative surgery is recommended. On the far right, class 1E is the most ideal. You see that the bone is surrounding the implant. There's a circumferential bone that has the best prognosis. When there's bone defect like this, as shown on the bottom right, you can remove the inflammatory tissue and do decontamination as best as you can and provide treatment. I think this is AstraZeneca. The local clinic referred this patient to me. The bone loss was severe, and you can see circumferential bone defect. I decontaminated. Bone graft was done, and this is after healing. This is at initial visit, 2 weeks later, 5 months later, and 2 years later. There is slight bone loss after 2 years. However, if you look at the mesial area, compared with the initial visit, it is well maintained. Finally, this is a summary. Overall, this kind of implant treatment is called Cumulative Interceptive Supportive Therapy, CIST. We can do non-surgical therapy first, mechanical treatment, and provide antiseptic solution, give local antibiotic, and if necessary, provide systemic antibiotic. If surgery is required, make a decision whether you're going to do resective or regenerative surgery. If things don't improve, you need to make strategic explantation, take out the implant, and do reimplantation. You need to make a quick decision. The best treatment, in my opinion, is prevention. You need to prevent any problems from occurring in the first place. You need to make accurate diagnosis when you do surgery and provide accurate treatment. You need to routinely look at the clinical radiographic data and develop your maintenance program in order to manage your patient. This is what I wanted to say to you. Thank you. On the chat screen, there are many questions. TGIF looks like someone who enjoys Fridays. Professor Jo, I'm enjoying your lecture. 2 thumbs up. Xiu is saying that I really look up to you, professors. Park is saying that there were a lot of concerns regarding Peri implantitis. He or she appreciates the good lecture. A different Park has also left a comment. I think the Park is his or her last name. What are the things that you need to look out for in terms of Peri implantitis related to prosthesis? I'm a prosthodontist. To give you my opinion, basically, mesiodistal distance of implant and buccolingual position. The path is important when you place the implant. If you do something wrong in that step, peri-implantitis might occur. If the prosthesis is over-contoured, sometimes patients request that. They want big prosthesis. So prosthesis may be big, but implant is actually thin. Because it is over-contoured, peri-implantitis can occur frequently because of food impaction. Margin, you can adjust it later. If you make crown too big, it can be a problem. In the past, we used to make it really small. I think the size has doubled recently. You don't need to make it extra small, but over-contouring is not good. The young generation has become much more bolder. The principle is to adjust the size of the crown buccolingually and mesiodistally, and the path as mentioned earlier. In full edentulous case, it's very difficult to find the path. Guided surgery is very good in that point. One guide can be used. As mentioned earlier, cement could be very problematic, and there are many cases. It can occur to anybody. I'm a prosthodontist, so I've seen a lot of cases. You think that you have removed all the residual cement, but there are still remaining in some cases. Sometimes you need to do local anesthetic and then scrape it off. Even then, inflammation may not improve. And when you open flap, you see even more remaining, plastered very thin. It's a problem, and it does not even show on X-ray. Another word of advice is do not place the margin too deep. At times, it is placed too deep. You don't have to do that with recent developments. If the margin is too deep, it is difficult to remove the residual cement, and you come across those cases more often than not. The rest, I think, can be addressed by Professor Joe. You need to have the right contact point so that food impaction can be prevented. Between natural tooth and implant, in most of the patients, experience this problem. It's quite difficult to solve. At first, it might fit, but with time, natural teeth would mesially drift, whereas the implant would remain still, so contact point can become exceedingly tricky. If it is screw type, you can remove it and add some porcelain. Sometimes, if it is not possible, you can dig a hole and put the resin in it, like every cavity. Other people do inlay, and there are multiple ways to solve this. Contact has always become an issue, and when you design the prosthesis, you can factor that in to prevent such problem. Yes, some people, when they make a gold crown on the contact area, mesial or distal contact area, they make a small hole where the undercut is, and laterwards, resin is filled there. You can do that because a lot of patients suffer from food impaction. Next week, Professor Im Young-jun is going to talk about embrasure space. Appropriate embrasure space needs to be made so that Proxa brush, which is approximately 1.2 millimeter, and needs to be able to go in. Embrasure space, if it is too big, it can be a problem, and if it presses upon the gingiva, it can cause problem. Therefore, embrasure space is very important. For the rest, I don't think it's something that I can address. There's another one from Conquering Prosthodontics. In regards to Peri implantitis, is there difference between implant designs and surface? And if there is difference, how can we improve upon it? Implant design has been mentioned. We have talked about how it needs to resemble natural tooth form. There's the issue between different companies, and I talked about how I reviewed 1,692 implants, and I wanted to mention Bronnemark and Straumann in the paper. I wanted to review 2,000, but as I was working on the paper, people advised me against it because there could be legal problems. Everyone wants to provide best product. I mentioned this before, but I want to emphasize once again that this is my personal opinion, and there are some things that I cannot talk openly. I think these areas are better known by the companies themselves, and I know that a lot of improvements have been made. Regarding design, food impaction needs to be prevented and over-contouring should be prevented. Bone loss is caused not just by periodontitis, but is also caused by overloading. And you need to... Let's look at the surface. In 1990s, I studied with you, and in 1996, I moved to Sweden. Sweden was mostly about Bronnemark implant. I thought smooth surface was the best. But when you do surgery, you're really stressed whether it's going to be also integrated or not. After 10 years from then, the trend has shifted to rough surface because it's more comfortable, and I think we found a middle point. The rough surface has more contact with the bone, and osteocytes get attached more easily, and I think we found a middle point between what is more too smooth and too rough. Osseointegration is done well, and peri-implantitis is discouraged. The design is the same thing. It needs to be improved continuously. I'm not sure whether you've noticed, but all implants and the shape are becoming similar all over the world. And this is because we're drawing to similar conclusions. Dr. K has raised a question. You've talked about adjunctive drug treatment for treating peri-implantitis. Can you make recommendations? You have already mentioned this, but can you emphasize once again? Use antiseptics like chlorhexidine, be it gel or solution. That is the recommendation for antiseptics. That is for sterilization. You can do irrigation and you can have the patient gargle. What is better is that you can do irrigation to the pocket directly. And I've talked about minocycline, tetracycline type, and you need to use good products. There are different components here. I cannot discuss openly, but there is difference. So I think it would be best if Osstem could develop a good product in this end. It needs to do slow releasing because it's a local delivery system. It's not common, but in severe cases, it is difficult to treat only with mechanical method. And you can also give the patient systemic antibiotic, fragile type, for 1 week or 10 days as adjunctive therapy. You can do combination therapy. You'll be able to get better results. It has been a very meaningful time. Thank you once again. Can you give a word of advice to the other doctors who are following in your footsteps? As a professor, I've been teaching dentistry for 35 years, and I think the most important thing is to enjoy what you're doing. It can be difficult, but accept that this is your calling. If you move forward, you'll be able to get good results. When you first place implants, it can be stressful, but if you do it continuously, you learn to enjoy placing implants. I think enjoying studying and enjoying your work will lead to good results. I think today's lecture has been of great help to doctors who were struggling with peri-implantitis. Thank you once again. Now it's time to end the prosthodontics on Friday. The answers that were not addressed during the live session will be answered via replies. From next week, top 5 issues related to implant prosthesis will be selected and addressed consecutively. The first lecture will be given by Professor Im Young-jin of Seoul National University Prosthodontics Department under the title Occlusal Surface and Embrasure Design of Posterior Implant. Thank you for watching once again.
자, 우리 조우선 교수님
시간은 맞춰
감사합니다. 고생 많으셨습니다.